I'm Harvey Getzoff, and this is my 9th and 10th papers today in this process. I love it. I love the fact that Charles gives so much great support and help, and I think it's a great process. I'd like to see a lot more chiropractors get involved with it. Anyway, my paper is on, and Charles always has a knack of getting similar subjects close together, and my paper is on the predictability of outcomes that can be very useful in the initial examination. Okay, purpose of the paper is really to get data in your examination that can help you understand what treatment and management plans you could utilize and what clinical decisions you need to make. And that's the whole idea. We use 4 SOT adjustments. One of the beauty parts of this is the SOT adjustments actually are, we're going to go into this, are non-invasive. So you can use them in an examination which can give you data. It's almost like the indicators that we use in SOT and examination findings are very much the same as the adjustments we use. We can use adjustments to collect data early on to make decisions, like I said, in treatment and management plans and our clinical decisions. The objective that I started out with was to establish more effective treatment and management plans, improve my clinical decision making, but actually it was really the overriding thing that I wanted to accomplish was to be comfortable that my expectations and the patient's expectations were similar. And by working towards that goal or towards that objective, I've really learned a lot. I've learned a lot not only about the patients, but about myself. And it's really been helpful in my office. Okay, an example. Patient walks in with cervical pain. I do a cervical rotation. I find the limitations. I apply adjustment. This is in the examination. I apply figure 8 and stair step adjusting. I remeasure it. I note the change in the cervical rotation. So I have a post finding, and I get an expectation or the level of recovery that I anticipate. And that level of recovery helps me, the data I collect for that level of recovery helps me manage the patient, set up a treatment plan, and also decide on the clinical decisions that I wanted to make. Here's an example of what I'm talking about. EW, we'll call her Elaine because that's her name. We'll call her that. She has the sunshine over there because she's really a person that lights up the room. 67, 68 years old. Her initial visit was 12/12/14. Neck pain, pain on traps, side of the head, all on the right. Difficult sleeping because of the pain. 10 days it's been severe, and there's the medications. Her findings, category 2, left head position, cervical rotation was 30 degrees to the left with a lot of pain. Flexion was 10 degrees. Trap fiber, right leg deficiency, left lower arm fossa, cranial sutures, right malar, temporal, left occipital, and the x-rays were, elaborate, she had lost the cervical curve, a lot of degenerative changes. We did the figure 8 range of motion study. After the figure 8 and stair step, she improved to 60 degrees, which I thought was a nice improvement, even more than I was anticipating. My treatment and management plans for her, and keeping in mind that she's really a kind of person you really could work with. Pain, yes. I thought I could tell her that we could help you with your pain. We could get better function, but it was limited. It was guarded, emphasized home care. She was the kind of person that just took that and ran with it. And in fact, I felt we could be successful. We set up a treatment plan. She was in just prior to making up the slide for our monthly check. She's basically out of pain. She, when you test her and do range of motions, she has limitations, and I expect that. But she's managing it, full-time managing it, and coming in monthly for an adjustment. It's worked out real well. So SOT examinations, looking on the right side of the arrow. The adjustments in SOT, so many of them, we're going to go over 4 today, but
So many of them are non-invasive. And you can use them diagnostically and then retest them, and you make a prognostic assumption of what you can do. And it makes the relationship, not all one size fits all kind of approach to every patient. Each patient's different. Each patient's clinical needs are different. They're a different person. Your relationship is different with them. Okay, we all know the 3 categories. And I'm going to just go a little bit off the side a little bit here. We know our 3 categories, Category 1, Category 2, Category 3, the heart of SOT. For us, we all, as SOTers, have something special. We can take somebody with a cervical problem like Elaine, that I was just talking about, and with her neck problem, we can put her in a category, and we can do so much more for her just doing the category adjustment. Just doing the category adjustment alone. I think somewhere down the line here, and I'm sure somebody's done it, just use Category 2 blocks on somebody who has cervical limitations and just retest them after you fulfill after you've done the blocking procedure. But anyway, within it, we make a diagnosis of the chief complaint, like we did with Elaine, her neck. We work that into the category, and we work the specific adjustment into the category. For Sir Elaine, the adjustment was Category 2 blocking, trapezius work with the thoracic spine, cervical figure 8 and stair step, and sutural adjustment. We have a big advantage by having the specific need that they have within the category that they are most need of being adjusted. Calais says it this way: a condition must be anatomically localized, mechanically understood, and pathologically classified. I think that's very succinct. We can localize specific things. Figure 8, stair step help us. Range of motion studies are a system of getting feedback on how we're doing. Desjarnais says it this way. I love this quote: when referring to figure 8 and stair step techniques, these particular cervical techniques combine analysis and corrections. And so much of what we learned in SOT is they blend together. The analytical data that we collect on examination can be further enhanced by utilizing SOT procedures within the examination. Now, there's the figure 8 and stair step. We all know that. There's the 4 types of, the 4 adjusting procedures that we integrate in the examination. Neck pain, we do a sitting cervical rotation. We do figure 8 and stair step, retest it. We get a sense of how that patient's going to respond to our kind of adjustments. Hip pain, prone iliofemoral rotation problem. We're just externally rotating the hips in a prone position. Iliofemoral goading technique. We goad it on the examination and get a sense of how they respond to it. Back and or leg pain. This I did a paper about 2-3 years ago that actually, my favorite thing I ever did, but back and or leg pain, we even, with Charles's help, we even had a poster at the RAC conference a couple years ago. You do a straight leg raise, you do a sitting desk technique, you retest the straight leg raise, you see the change. In my opinion, what's changing is the ability of the lumbar spine to go into flexion. Good data on somebody that has a lumbar problem. Really good test. We did 30 patients, I believe, where we studied their pre and post findings, just sandwiching straight leg raise, sitting disc technique, straight leg raise. And we had some really good results. It's great feedback on the initial exam. Buttock, leg, and back pain, you can do the step out maneuver. And then you can do category 3 blocking. Of course, this one has one occlusion. One we can't occlude is that you can't do category 3 blocking if they have an arm fossa. But if they don't have an arm fossa, there's no reason not to do category 3 blocking. See how they do. Desjarnais set up a procedure, and it's all in all of his books, of analyzing each
step out, toe out maneuver and collecting data on each one. Desjardins did it. We did it in a poster where we just added in some additional things a couple years ago, and we did a paper on that here. But there's no reason you can't do category 3 blocking to do it as long as they don't have an arm fossa finding. Okay, here's a young lady. Came in 11, she's born, so she's about 28. Her first visit was just about a month ago. Concern, left sacroiliac and iliofemoral pain, night pain, onset September 12, but she's been dealing with it. She's not heavy. She's in great shape. She's a very positive person. We could have put a sunshine up on her too. She's great, and she wanted to continue running, but every time she ran, she had this sacroiliac and iliofemoral pain, and it woke her up at night as well. Category 2, there's leg deficiency, arm fossa. She had a left iliofemoral, head position right, which is really good data. Head position right on the plumb line, good data on somebody that has a left iliofemoral problem, because she had her head position right here was much lower than the left, but the EOP was on the plumb line because she was loading onto the left side of her body and loading onto that hip. So posterior findings, post findings. The left iliofemoral adjusted in the examination by goading it, and it improved significantly. So I thought we had a good chance of helping her with it. I also felt that we had to get good change in the cranium, so her head position was better, and I had a great thing helping me because she was a past patient of Dr. Chinapi. She had a good bite. I knew once we started adjusting, this is Michelle that we talked about. Once we started adjusting the cranium, she would respond, and she did. She responded real well. We gave her some home care, an exercise. This is actually a step out, toe out exercise that I learned from Desjardins. And we have favorable outcome too. Favorable outcome, and it worked out really nicely. And that data we collected, I thought we could help her a lot. There is the step out, toe out. Off the blocks, it's a test. On the blocks, it's an adjustment and a test. There's a sitting disc technique. There's the key to sitting disc technique is to separate the spinous processes on flexion. This is something we did that we integrated into the step outs procedure. We call them scenarios 1, 2, and 3. If a patient comes in leaning to the opposite side of pain, it doesn't go below the knee, very favorable. If they lean to the same, it's sort of bulging disc kind of scenario. If they're leaning to the same side, it's pain, and if it goes below the knee, it's much more cautionary in your guidance of that patient. It's a medial disc as opposed to the first one being a lateral disc. It's more problematic and more cautionary in the treatment plan and in the management plan discussions, consultations that you have with that patient. If they have, and it doesn't matter much which side they lean to, but if they have significant, constant, unbearable kind of pain in the calf, positive and a possible positive heel-toe test, difficulty sleeping, and a SOTO test with no pain, which is significant, that's a person that you got to tell them you don't know if you can help them. And you set them up in a sort of conditional manner, which is what I've done. Okay, here's a young man. So he's something like 40, 47, or he's going to be 47. That's his first visit just recently. Low back pain, right anterior upper leg pain. He had one time injured his groin severely. Numbness knee to lower leg, duration 20 years, this episode 2 weeks. Difficult standing and standing straight. So if he held on to a table, he had to hold on, he couldn't straighten up. Findings, obviously, category 3. I shouldn't say obviously, but he was a category 3. He had a left lean in the spine, and he had a lot of restriction in the right iliofemoral and restrictions in the right SOTO. We did the sitting desk technique in the examination. As part of the examination, we redone the straight leg raise. It was 40 degrees with a lot of pain on the right. He had no arm fossa findings, so we could put him on category 3 blocks in the examination. The right iliofemoral SOTO category 3 block, it limited, but it improved. It improved some. The sitting desk technique, lean, improved, but the SOR limited change. What that all means is when we stood him back up on the plumb line, he had a left lean in the second paragraph there. We stood him up on the plumb line after we did the SDT. He wasn't leaning anymore. Yay, that's great. Okay? Plus, his pain was on the opposite side of the lean to begin with. So he's a favorable outcome. The only thing is, I didn't find much change with activating the iliofemoral on the right. I didn't find much change with doing SOTO block, category 3 blocks in SOTO. So I was real cautionary with him in the beginning. He's a great young guy. He did all that we asked of him. He's doing great. And it's worked out real well. And that's how we utilized a lot of data on the first one. Plumb line, right hip, right SOTO, and SLR, all used in the examination to give us data. Management, this is a guide. This isn't specific. This wasn't measured. But you know, when you're trying to change something, and it really doesn't change much, you know, I like to use the words marginal and maintain as far as a management plan and patient expectations. I put a little star to that because they carefully have to be managed all the time. It's a problem that's not going to go away, but if they manage it and they get care, maybe they can maintain it, maintain an improvement. Of course, I try to use words like helpful and improved as we get more. I try to stay away from words like perfect, cured, and fix. They're not good words. I think we should ban them completely from, we do, but we try to stay away from that. Try to stay with that, keep that all, trying to manage them with these kind of concepts. Okay, MP is a guy that just came in. His initial visit was 428. I put a lightning bolt next to him because he has a lot of problems. He walked in the door and said, my father-in-law said, you'll fix me right up. And he wanted to be fixed right up. Okay, there's that fixed word. He had low back pain around the right crest area, right lateral leg pain, calf pain, calf pain, night pain, night pain. He leaned left, and he had the pain on the right, so that's good. We did a right SOTO, we did a pre and post. On the SR, it was very limited, and he could not walk on his heels. So, in my opinion, based on everything he has a herniated disc. He has no MRI or findings or x-rays. So he's a category 3. We put him on the blocks, did the SOTO, we cleared the arm fossa that wasn't there. We did SDT, sitting disc technique, and he still had the left lean. So, what can I say? I was very cautionary with him. He's very anxious to get better, but he's also a good person and a good listener. So we just caution, with a lot of caution. We've given him about 3 adjustments to this point. I think he feels like he's getting somewhat better. I feel like some of these things have changed. And the interesting thing about it is I've been emphasizing this is all data collected in the examination, but it's also ongoing. So it looks like he's coming out of the lean about the 3rd adjustment. That's good information, really good information. His straight leg raise is improved a little bit. He's very, he creates his own dialogue with talking about the things that he could do to help himself. And he's anxious to get better, but he's moving along. Now, treatment plan, just to specify what a treatment plan is, that's a length and frequency based on ongoing examinations. And what we do, we've set this up, it's been part of what we do in our office a long time. It's a graph. So these are all our tests and our SOT work. And then we just keep going down the row, down the row, down the row, trying to compare each adjustment to the previous adjustment or the previous adjustments. See? Just keep doing it. And this kind of graph, and it's framed by all kinds of information. The information we give them about instructions for the cervical spine, the lumbar spine, exercise, dental referral, okay? Even the dental findings up here. So there's a lot of it. X-ray diagnosis. There's a lot of data on this, and we use it very, it's a great method of following the patient's change from visit to visit, because all this stuff that we're using in the initial exam can be checked each time they go on. So it's an ongoing process. The management plan is the more the testing indicates that there's limitations, the more you have to get the patient involved. You're constantly making, I use this to make, we check it each time they come in and recheck it that we're making all the right clinical judgments. A lot of advice and guidance, obviously, the more they need it. Calais again, irritated tissues must be ascertained as removable, reducible, and irreversible. So he's got it 3 things. I say removable, irreversible, and a lot in between. And that's where we got to find this. You know, I sort of named this for myself as a sort of a critical thinking chiropractic. You know, you got to be open-minded about things. You have to be clear about it. You have to find your own evidence. And it's been a great experience for me looking at each person and the data we collect on each person and the process of creating a dialogue with them sort of, for me, reaches a deeper level of the relationship between me and the patient. Conclusion, the non-invasive nature of these procedures adjustment allows for a deeper understanding of not only nature of the problem, but also its level of severity. Another conclusion, I just threw this in here. There's a young man, came in a while ago, had severe headaches. He was at the Jeff Headache Clinic in Philadelphia, big time headache clinic, which at Jefferson Hospital in Philadelphia. Interestingly enough, he was a failure there, even though they had him on some pretty powerful medications. It's a headache clinic, but all they do is load you up with medications. And when he came in, he had an orthodontic problem. He was referred to both Dr. Chinap and myself at the same time by a chiropractor who doesn't do cranial work, who knows that I and Dr. Chinap work together. Had an orthodontic problem, which he started simultaneously with adjustments with me and at the same time with Al Chinap. He was a category 2 and had cranial problems, but also he had a line 2 fiber T6. Now, A is I knew he was getting proper orthodontics. B is I felt confident in my diagnosis of him and my analysis of him. And 3 is he was real open to further discussion about what he could do to help his blood sugar. I personally think line 2s are amazing. Not only does it gives you analytical data that tells you what's inside a person, but when you have a line 2 T6 pancreatic problem, that's there for life. And this guy's a category 2 for life. Put that little asterisk there to remind myself. He's a guy that's, in my opinion, is always going to be a category 2. He's always going to have a line 2 T6. Is he out of pain? Yes. Is he managing his diabetes? Yes. Is he coming into my office periodically for adjustments to maintain his level of function? Yes. So he's done really well, and that's it. Thank you very much.